I absolutely believe that the first responders are kings and queens because I take care of kids. I'm fond of saying I take care of kids in the Crystal Palace. Everything I think I want, even if I think about it, may not even have to articulate it. I just think about it, and it shows up.
It's just there for you.
Yeah.
Yeah.
But life-saving really starts out there in the field with you guys hanging upside down from a bridge in the rain, in the dark, with a flashlight, trying to intubate someone and extract them. That's where life-saving starts. So, if I can do something that contributes to the knowledge base of that group that's saving lives, I feel like that's my duty.
Thank you. I think it's big for all of us. I know we really appreciate that. It's always nice if we can try and offer something special to our people, whether it's at Care Flight or anywhere else, that it just makes us better, 100%. So we really appreciate that. I want to talk about the lecture that when Dr. Guzman came to you asking to do a lecture, what initially were you thinking you were going to talk about? What was that topic going to be?
Well, he mentioned pediatric airway,
Okay.
and airway management, because I was a residency program director and a fellowship program director. So teaching pediatric airway was something I did monthly.
Really? So, I mean, we have this whole list of topics right here that we're going to dive into, but I think I'd rather choose this more as a reminder in case I forget to ask anything, but I'd love to just hear like the synopsis really of what that lecture is going to be about.
Okay. So when I talk about the pediatric airway, I highlight the fact that there are 5 or 6 major differences between the anatomic differences between the adult and the pediatric airway, and recognizing those is critical. If you don't recognize what that list is and you don't understand the clinical implications of each of those factors, then kids are at risk. So I usually go through the list of the major anatomic differences between the adult and pediatric airway and then the clinical implications thereof. And I can go back and do that. I also do emphasize the philosophy behind laryngoscopy. I mean, understanding the philosophy, what you're trying to achieve, because you don't think through that, but if you understand the philosophy of the laryngoscopy process, then you do laryngoscopy correctly. If you don't understand what you're actually trying to achieve, Solomon, one of the wise men of the Bible, said, "In all you're getting, get an understanding." So if you understand the laryngoscopy process and what you're trying to achieve, then your technique is likely to follow and be better.
Sure.
So I give that laryngoscopy philosophy approach.
What is the philosophy of laryngoscopy?
Okay, if you ask me that, I will say this.
Yeah.
So I'm going to launch into my little spiel.
Okay.
I mean, anyone who's come through the airway day, if I'm there, they've heard my little spiel. My spiel is laryngoscopy, conceptually speaking, is an attempt to align the 3 airway axes inside of a given visual sphere so that you can look in the mouth and see the vocal cords. The 3 visual spheres, let's say the kid is lying on the table, feet that way, head this way, nose pointing up. The oral axis, which is perpendicular to the child and perpendicular to the bed. The pharyngeal axis, which is parallel to the child, parallel to the bed. And the laryngeal axis, which is slightly anterior to that. So what you're trying to do is align these 3 airway axes inside of a given visual sphere so that you can look in the mouth and see the vocal cords. If you understand that it's not a flat circle, that you have a cylinder going from the mouth down to the glottic opening, then if you conceptualize that, then you understand that you don't do this wrist rocking motion when you're doing a laryngoscopy. So laryngoscopy is an attempt to align the 3 airway axes inside of a given visual sphere so that you can look in the mouth and see the vocal cords. The size of the visual sphere is really important. The larger the visual sphere is, the less well aligned the 3 axes have to be, and you can still look in the mouth and see the vocal cords. The more restricted the visual sphere is, the more you have to have those 3 airway axes lined up, one right on top of the other in order to look in the mouth and see the vocal cords. Well, that's the difference between adult and pediatric laryngoscopy, is you have a difference in the size. That's not the only difference, but that is a big difference. You have a difference in the size of the visual sphere. So if you have a smaller visual sphere, well, let's go back. If you have a larger visual sphere, you can get away with, and I don't mean this in an insulting way, but you can get away with less precision in your laryngoscopy technique.
You have more wiggle room.
And you still successfully intubate the patient. But if you don't hone those skills so you're really precise in aligning the airway axes, then you go to intubate a kid and you find out you can't align those three axes, or you can't see the cords because the axes aren't lined up. So I really think that the size of the visual sphere matters in aligning the three airway axes. And if people catch that, then they understand that part of your process is pulling the anterior wall of the cylinder more anterior so you can align, so that you can have a larger visual sphere. Plus, you have these 4 quadrants in this visual sphere. Tongue control becomes absolutely critical. If you've got a visual sphere that's broken up into 4 quadrants, you understand the critical nature of tongue control and laryngoscopy. You've got this small visual sphere. You want to relegate the tongue to this one upper quadrant of the visual sphere. So you've got 75% of the small visual sphere in which to align your 3 airway axes. Understanding the concept matters.
Mm-hmm. So what increases or improves precision? So you talk about with these small kids needing precision to be able to line those 3 axes, right, and to be able to see that glottis. How do you, I guess, how do you prepare yourself, and how do you prepare yourself in the pre-intubation phase to have the utmost precision for these kids?
So can I expand upon that a little bit? What I would do is I would start by emphasizing the anatomic differences between the adult and the pediatric airway. Awareness of each one of those differences really makes a difference. So, for instance, you have to make sure, you have to be aware of the fact that the tongue is larger and the visual sphere is smaller. So tongue control is absolutely critical. The preferred blade for laryngoscopy in pediatric patients, the smaller they are, the more this principle matters. The preferred blade is the straight blade or the Miller blade, because it further enlarges, it displaces the anterior pharyngeal wall soft tissue more than the curved blade does. So it gives you a larger visual sphere within which to align your airway axis. So part of my preparation is making sure I have the right equipment, and a Miller blade or something of that sort really matters. My preferred blade, honestly, and I don't see it very often anymore, my preferred blade is a Phillips blade. Okay. I call a Phillips blade the Miller Mac hybrid. Okay. Because it's got that little curved tongue at the end, but in the body of the blade, it's straight, so you get more anterior pharyngeal soft wall tissue displacement. Secondly, again, recognizing the anatomic differences. If you understand that kids have, a concept of laryngoscopy is you want to get the patient in sniffing position. Sniffing position is a position in which you have the optimal airflow from the mouth down into the glottic opening and into the lower airway. With adult patients, you achieve that by putting a pillow underneath the head. But if you understand that one of the anatomic differences between an adult and pediatric airway is kids have a large, prominent occiput, that you don't place yourself in a position where you place something underneath their head, you hyper flex their neck, and then you try to compensate for that by hyperextending their head-neck junction. And so now you got this really anterior airway, making laryngoscopy that much more difficult. In fact, maybe even impossible. Mm-hmm. So understanding the anatomic differences matters in your preparation for managing that airway.
Mm-hmm. So now let's say you have your equipment ready and you're ready to pass the blade through the mouth, right? Ideally with any patient population, whether we're doing adults or kids, it's typically going to be a very similar process where you're not cranking backwards, you're lifting upwards, anterior. They teach going to the corner of the room, right? You're sweeping the tongue out of the way. Ideally, we would want to have precision for everybody, right? Whether it's adults or kids. But how do you, once you are with the blade in the mouth, how do you then use that equipment to be the most precise that you can be? What are you doing very specifically with that blade to displace that tongue properly into that quadrant and to get that perfect alignment of your axis?
I understand. So first part of your approach is getting the blade in the mouth properly. Cool your jets, calm your catecholamines. Yes, you got a limited amount of time to get that tube in, because at that point, for you guys particularly, often your patients are already desaturated. Mine are not. Mine are pre-oxygenated. That's why I live in the crystal palace.
Right.
But take your time to do it right. Positioning and technique absolutely matters. Get your blade all the way over on the right, trap the tongue on the anterior pharyngeal wall, but in the left side of your blade, don't have your tongue floppy over the blade. You really want to make sure that you take the second or two that it takes to really trap that tongue behind the blade. And then I understand that there are two different approaches to this, and I'm not here to criticize one versus the other, but I think you should do nothing blind. So I don't think that the optimal approach is to bury the blade down into the esophagus and pull back. That is an approach. It is taught. I'm not criticizing it, but I think you should do nothing blindly. So when you put the blade in, you want to see the tongue at the tip of your blade. You walk the blade down, seeing your tongue until you get to where you visualize the epiglottis, and you can make a conscious decision, spot decision right there as to whether or not you want to trap the epiglottis or go into the vallecula. That's the beauty of a Miller blade. A Miller blade allows you to go into the vallecula, push on the vallecula, causing a tensing of the hypoepiglottic ligament, and hopefully the epiglottis slips up. Sometimes it doesn't, because that's one of the anatomic differences between the adult and the pediatric airway, is the epiglottis can be large, floppy, and 45 degrees posteriorly angulated. So it may not work, but then you can also make a conscious decision to go down, pinch the epiglottis underneath your blade, and then bring your blade to midline. So now you trap that tongue in this quadrant.
Okay. I've heard there's another method that I've heard some other people use before, and these aren't pediatric clinicians by any means, or pediatric exclusive, is they'll size up the blade. So maybe that they'd elect to stick with a Mac, but say this kid needed a Mac 1, they'd go in with a Mac 2, and they'd choke down on it a little bit. So then when they follow that tongue in like you described, you make that snap decision, am I going to trap the epiglottis or aim for the ligament? If they feel that they're unable to aim for the ligament, they need to trap, they can just let out some more of the blade because they have the longer Mac they needed, and try and trap with that. How do you feel about that approach of using the longer Mac with just using a Miller?
Yeah. So, Dan, I will qualify my comments by saying I'm not telling any experienced clinician what they ought to do.
Sure.
You do what works for you. There's good, solid literature in the anesthesia literature that says when anesthesiologist A tries to do the technique that anesthesiologist B has perfected, he's likely to get a bad outcome.
Right.
Anesthesiologist A, she used anesthesiologist A's technique instead of trying to duplicate someone else's. So I am not trying to tell any
100%.
experienced clinician how to do things. Let me tell you why I choose a technique, why I choose not to use a Mac blade, although you can definitely use it in that technique. The benefit that a Miller blade offers is more anterior pharyngeal wall soft tissue displacement. A Mac blade, because it's curved, has a limit to the amount of anterior pharyngeal soft wall tissue displacement that you can get. In addition to that, while you do get a longer blade, when you use a larger Mac, you also get a larger blade.
Yeah.
So you've already got a restriction in the size of the visual sphere because it's a pediatric patient. Now you've cluttered more of that visual sphere with a larger blade. So a smaller, straight blade is, in my opinion, hands down the preferred technique. If you want the benefits of a curved blade, then, in my opinion, the Phillips blade would offer you the best of all worlds.
That makes perfect sense, because you just start taking up real estate in that very small little cylinder that you have that otherwise just would not be available. So I think we skipped a step here. I need to go back real fast. We talked about the setup and the preparation. Could you talk a little bit about pre-oxygenation, about how you like to approach the pre-oxygenating the patient, the pediatric patient?
I'm gonna come right back to that. Let me see, and I think that's a critical subject. I'm gonna say this: airway obstruction, because of the anatomic differences between the adult and the pediatric airway obstruction should be considered the rule, not the exception in pediatric patients. And I will say this, that you will say, I used to teach this to medical students, residents, fellows all the time. It's a critical point. You will save more lives doing bag mask ventilation than you will doing laryngoscopy. So since airway obstruction is the rule and not the exception in pediatric patients, when you're managing a pediatric patient, you should anticipate they're going to obstruct. You should have an oral airway or nasopharyngeal airway not buried in your bag, but out and ready to use, so that if and when the airway obstructs, you can bag mask ventilate that patient and overcome the obstruction and give yourself less tension on time to intubate, because you've given them some oxygenation.
Do you find that NPAs and OPAs are usually adequate enough to manage the anatomical obstructions that the patients are having?
I think it's very useful. Yeah.
Yeah.
In this era of laryngeal mass airways, you got that option too, and that's an even better option.
And go ahead. That was a question I was going to ask you. Also, is the use of we don't have LMAs, we only have iGels available to us on the helicopter or the ambulance. Have you ever attempted pre-oxygenating with one of those?
No.
With an iGel or anything like that?
No.
Yeah.
Again, my scenario is different than yours. You're out there in the field with an unsecured airway and an arrested patient. I'm pre-oxygenating people who are breathing spontaneously, who are in their normal physiologic state. So that scenario doesn't apply to me at all. So go back to the pre-oxygenation. I think pre-oxygenation is a critical concept that really has clinical significance. So back in my day, the concept of pre-oxygenation, and I say back in my day because it has changed. In 1999, in September of 1999, in the journal Anesthesiology, there's an article that redefined pre-oxygenation. Back when I was in training, adequate pre-oxygenation was defined as you either breathe normal tidal volume breathing for 3 minutes, or you take 8 vital capacity breaths. It was 100% oxygen. That was adequate pre-oxygenation. That was optimal. And this is important because of the physiologic differences. I'll come back to that. I talked about anatomic differences, but there are physiologic differences between kids and adults. In September 1999, our edition of the journal Anesthesiology, there was an article where they actually did a study. They took 3 populations of patients. They pre-oxygenated them by 3 different techniques. One group got 3 minutes of tidal volume breathing of 100% oxygen. A second group got 4 vital capacity breaths of pre-oxygenation, 100% oxygen. And a third group got 8 vital capacity breaths of 100% oxygen. And then they measured their PaO2 of all of those patients. What they found was there was no statistically significant difference between patients who got 3 minutes of tidal volume breathing of 100% oxygen and patients who got 8 vital capacity breaths of 100% oxygen. But there was a statistically significantly lower PaO2 in patients who only got 4 vital capacity breaths. So you really kind of need 8 vital capacity breaths.
Okay.
While that's true, the reality is we probably don't pre-oxygenate because we're worried about patients desaturating. We're probably, because we're going to intubate them fairly quickly.
Right.
So even though there's a statistically significant difference, there's probably not a clinical difference in pre-oxygenation.
Okay.
And I just read I just did my CME and saw that there was a article, and I'm sorry I can't tell you the reference, but it was in my list of 200 questions, that now with high flow nasal cannula pre-oxygenation, that is considered actually as adequate. In fact, those patients don't desaturate any faster than the patients who get a full occlusive mask fitting with 3 minutes of tidal volume breathing, or 4 vital capacity breaths, or 8 vital capacity breaths. So
does that assume the patient is breathing spontaneously? Or
Yes.
Apneic oxygen. Okay.
yes, that does.
Gotcha.
Again, my patient population is different than yours.
No, I mean, not necessarily, not entirely. I'd say a lot of the times that we intubate a pediatric patient, Ray here, he does a lot of our chart reviews. I would say most of our pediatric intubations are probably TBIs, head injuries type stuff. So, they'll still be breathing spontaneously as well. They just have that low GCS that is
Their tidal volumes are probably lower. They've got a depleted FRC. So we talked about the anatomic differences, but the physiologic differences between an adult and a pediatric patient are also.
Actually, I want to stop you real fast before we get into that, because I have one more anatomic question. How do you anatomically approach positioning and BVMing? So we talked about using the bag valve mask for pre-oxygenation and everything and controlling that. Are we doing the same jaw thrust that we do in adults? Obviously, the positioning is not the same with the blanket behind the head. How do you approach the positioning and the management of the bag valve mask?
Well, I will say this. Again, because you have a smaller oropharyngeal cavity and a larger tongue, you have a greater propensity towards airway obstruction. Hand finger placement really matters in a pediatric patient. If you let your finger slip too far midline when you're doing your jaw thrust, your fingers are going to be pushing on that anterior pharyngeal soft wall tissue and pushing it into the airway and increasing your airway obstruction. If you have a totally unconscious patient, take this for what it's worth, but I would say if they're totally unconscious, an oral airway, think about an oral airway or nasal pharyngeal airway to keep the airway patent. And I think it should be something that you go to sooner rather than later. Again, I recognize that maybe that might increase if patients semi-conscious, it might increase their risk of nausea and vomiting. And that's a downside. So you guys have to use your professional judgment and say, wait a minute, maybe I don't want to do that. But from an airway obstruction perspective, an airway adjunct to minimize the likelihood of airway obstruction is really, really important.
Perfect. So sorry to interrupt. I appreciate that. The physiologic differences. Now.
So there's 3 or 4 very important physiologic differences that matter in pediatric patients. One is their minute ventilation is different. One is their oxygen consumption is different. And then when it comes to their lung capacities, those are different. So from a critical airway perspective, the minute ventilation matters in anesthetic inductions. You ask some questions that pertain to anesthesia inductions, and that's a little different ballgame. But the minute ventilation really matters in my world because it affects the rate of induction. The oxygen consumption truly matters in your patient population because the younger the patient is, the higher the oxygen consumption is. So even if you adequately pre-oxygenate them, the time that it takes them to desaturate is substantially shorter window than in the adult patient. I mean, you and I, the typical adult patient, the oxygen consumption is about 3 cc's per kilo per minute. In an average pediatric patient, it's 5 to 6 cc's per kilo per minute. So they're going to consume oxygen twice as fast. But in a neonate, it can be as high as 9 cc's per kilo per minute. So they can desaturate 3 times as fast as an adult patient, even if they're adequately pre-oxygenated. So adequate pre-oxygenation truly, truly matters. If you don't pre-oxygenate them well, they're gonna desaturate really fast. Furthermore, in the neonate for sure, but then in kids under about 3 to 6 months of age, they also have all this fetal hemoglobin still circulating. So their hemoglobin is 50% saturated. It's shifted to the left. Their hemoglobin holds on to the oxygen and won't release the oxygen to the tissue. So they're more likely to have tissue anoxia, even if they've got a little bit of oxygen circulating. So these physiologic differences truly, truly matter, and adequate pre-oxygenation is absolutely critical for the little babies. The younger they are, the more it matters.
Interesting. I've never I didn't know that about the oxyhemoglobin association curve being shifted
to the left
for
in pediatrics.
For the neonates, for the pediatrics. Is there anything else that you do differently, whether it's airway wise or medication wise, that to manage that, to offset that, to anticipate that, or is it purely just a matter of pre-oxygenating these patients?
So I think it really is a matter of adequate pre-oxygenation and precision in your laryngoscopy approach. There are physiologic differences between pediatric patients and adult patients that impact our medication approach as well. I mean, the younger they are, the more they, well, I would say this, we're all big bags of water, right?
Right.
60, 70% water. But the younger they are, the more big bags of water there are. And not only that, but the greater portion of that water is extracellular fluid, which happens to be the space where our medications are mostly active. So kids are, in a newborn, they might be 70, 80% water, and 50% of their total body water is extracellular fluid. So you take those things into consideration when you're dosing various medications in pediatric patients. But we generally dose them on a per kilo basis. And so those routine patterns, those routine dosing approaches aren't changed. They incorporate those thoughts. And so we don't change those in a critical care scenario.
Okay.
Does that make sense?
Yeah, absolutely. How, so let's say we just take a random drug for adults and say the normal dosing of that is 1 milligram per kilogram. In the small pediatrics with the excess extracellular water relative to the adult, are they going to need more than 1 milligram per kilogram or less than 1 for an equivalent?
Doses might be increased on a per kilo basis. So for instance, succinylcholine, I know that's a drug of the past, but I think it has a few indications that it's still superior for. In the adult patient, that dose is about 1 per kilo. In a pediatric patient, it's about 2 per kilo.
Okay.
Because more of the medication is diluted into, the medication is diluted into a larger
Bag of water.
And so the amount of medication that the receptor sees will be less.
That makes perfect sense. The choice of induction and paralytics is something I want to come back to. So I think that's a fun conversation. But last little bit about management of the airway itself is, so then how do you approach, we've talked about like the ideal and optimal approach should the average patient you see in your Crystal Palace. What about before I name off any diseases or disease states or what have you, what kind of disease states do you see, or when you see the case on your schedule for the day, he says, that's going to be an interesting airway, and that's going to be a tough airway.
Oh, yeah.
What kind of...
So, as you are aware, there's something just short of 1 billion different syndromes. You can't possibly know all the syndromes. You can't. So when I would give these lectures to my fellows, I would tell them there's a handful of specific syndromes, which when you hear it, you got to know that has airway implications. And then you ask yourself if a syndrome falls into any one of those categories. So the categories of syndromes in my mind there are the syndromes associated with micrognathia, with mandibular hypoplasia. And the two that jump into my brain immediately are Pierre-Robin and Treacher-Collins syndrome. So if I hear kids got Pierre-Robin syndrome or sequence or Treacher-Collins syndrome, then automatically I'm going, that's going to be a very difficult airway. One of the only 2 kids in my entire career that I couldn't intubate was a Pierre-Robin kid. The other one was a Treacher-Collins.
And that's where they have a very recessed chin.
Have a very recessed chin. In addition to that, in the Pierre-Robin kid, they may have what's called glossoptosis. Glossoptosis is a posterior inferior retrograde displacement of the tongue. So instead of tongue sitting with the tip of the tongue out the mouth, it's actually sitting back. So the arc of the tongue is more likely to hit the posterior pharyngeal wall. So that can really complicate the intubation of a Pierre-Robin kid. Plus, Pierre-Robin kids often, well, not often, but may have a cleft palate, which further complicates the intubation. So Pierre-Robin, Treacher-Collins, those fall into my micrognathia category, small recessed chin.
Okay.
Then there's the mid-face hypoplasia syndrome kids. That would be like Apert syndrome or Couzon's syndrome. Those kids have the mid-face is sunken in, which also then leads to the anterior portion of the face being more proximate to, closer to the posterior portion of the face, and those kids have significant airway obstruction. So either mandibular or maxillary hypoplasia can lead to issues. Then there's Goldenhar syndrome, which is kind of it's called hemifacial microsomia, and they can have mandibular and maxillary hypoplasia on one side of the face. You might think, well, then I just intubate them through the other side of the face, but it doesn't work that way. So Goldenhar syndrome is a big deal. And finally, then there's Down syndrome. And Down syndrome is just a hyper exaggerated big tongue on top of everything else. So those are if you know those syndromes, and then you ask yourself, does the syndrome that I'm dealing with potentially have any craniofacial abnormalities that falls into any one of those groups? Then I know I might have a difficult time.
And how do you do anything different to manage the excessively large tongue of a patient with Down syndrome?
No, I'm just hyper vigilant with regards to tongue control when I intubate them.
Okay, gotcha. So now what about patients with more acute airway diseases rather than chronic or genetic, right? Like, for example, you said the ones like croup or epiglottitis or something. How do you manage the excessively inflamed, whether it's upper airway, vocal cords, the epiglottis, like what have you? How do you then approach those patients?
So
we know that they can be really sensitive stimulation, I'd say.
So I keep dating myself. It used to be that was a huge topic. But the incidence of acute epiglottitis compromising the airway is gone to zero. I haven't seen it in well over a decade. I don't know that I've seen it since I've been a cook. I can recall one call day where I did get a call and there was a kid that might have epiglottitis. And so my approach to that, and I'll come back to that, would be that kid comes to my OR for intubation, and they have an ENT surgeon around before I do anything. That kid never even came to my OR.
Okay.
Back when I was a fellow at Cincinnati Children's, I saw more than my share of epiglottitis. In fact, Cincinnati Children's had its own little protocol for managing of those kids, but we just don't see, because of vaccinations, we don't see acute epiglottitis that's airway compromising. The approach was that those kids, you try not to stress them, you keep them totally calm, you let them find their position of comfort, so they're sitting forward usually, they're drooling, you don't mess with them. You let them find their position of comfort. You don't get them distressed. They sit with their mom or in the arms of their parents. Leave the kid so their airway is resting. And then you bring them up to the operating room. You have everything set up. You do a inhalational induction and then you intubate those kids with a small, breathe spontaneously with a small endotracheal tube and take them to the ICU.
So you don't paralyze them.
No, oh, absolutely not, because that might lead to acute decompensation of the airway. So absolutely not. You do not paralyze those kids. Now, croup was a different story. And yet, even doing that approach that I just described, there was always the thought that these kids could acutely decompensate, and so the ENT surgeon needed to be around and ready to go that way. He didn't bring them to the OR without an ENT surgeon. Yes. Croup, on the other hand, goes back to one of the principle of one of the anatomic differences between the adult and pediatric airway, which I didn't mention. One of those differences is the narrowest point of the airway in the pediatric patient is, at least under 6 years of age, the narrowest point of the airway is below the vocal cords. In the adult patient, in every normal patient, regardless of age, day 1, year 99, in every normal patient, the narrowest point of the airway is always C6.
Okay.
But C6 is where the vocal cords are in the adult patient. But the pediatric patient, the vocal cords may sit as high as C2 to C4, but the narrowest point of the airway is below the vocal cords. Okay. So if that kid then gets a acute inflammation of their airway, as in the croup patient, then you have further exaggeration of the narrowing of the airway below the vocal cord. And so that patient population, when you do intubate them, you're intubating them with a smaller endotracheal tube, and you really need to intubate them kind of with finesse so you can actually feel the tube as it passes, after it passes through the cords, as it passes through that C6 area. Kind of want to feel how tight that tube is. Probably once you get the tube in, you're not going to take it out, though. Right. Because then, immediately you get encroachment of the airway with further edema just because of the trauma.
I think it's like it's nicely into the drugs here, because you mentioned not paralyzing the patient with epiglottitis. Are there any other patients where you would steer away from using paralytics? And also, let me also ask you another question related to that is, are pediatrics physiologically different from adults in the frequency of vocal cord spasm in the absence of paralytics?
So help me if I don't answer both of your questions.
Of course.
Let me start by saying that from an anesthesia perspective, we don't do inhalational inductions in adult patients. We do inhalational inductions in pediatric patients. That's important because when you do an IV induction, patient plummets from a conscious state down to a surgical plane of anesthesia where you can now and have to intubate them, and so their vocal cords don't have time to spasm because they plummeted from a weight down to a surgical plane of anesthesia where they are not responsive to a noxious stimulus. In pediatric patients, when we do this inhalational induction, it takes them a little time to transition from a weight down to a surgical plane of anesthesia. It's that period of time of transition when they're not quite awake, not quite asleep, we call that stage 2 of anesthesia. During that stage of anesthesia, they have a hyperreactive airway protective reflex. So they're more likely, in the face of a noxious stimulus, like trying to put the breather tube in, or like volatile anesthetic agents irritating their vocal cords, they're more likely to spasm their cords. So you don't see vocal cord spasm in adult patients on induction, whereas you do see it on pediatric patients because of the time to induction, the time of transition. You might see it in adult patients when you take the breathing tube out. If they're not quite awake and not quite asleep, then when that endotracheal tube slips past their cords, it might irritate their cords, and then they slam their cords shut.
Makes perfect sense. So let's say that you are unfortunately taken away from the beautiful OR suite with all of your induction gases, and all you have is 2 beautiful bilateral peripheral IVs. how are you going to be inducting those patients with IV anesthetics, sedations, analgesics?
So if it's a known difficult intubation, all I got is these 2 IVs, and I know I've got to get a breathing tube in them. I'm gonna do a slow, spontaneous. I'm gonna keep that patient breathing spontaneously. I'm gonna give them enough sedation and topicalization or other anesthetic medication, but keep them breathing spontaneously, and then I'm gonna secure their airway in their semi-conscious but spontaneous breathing state. If they are a combative patient that I don't anticipate I'm going to have difficulty getting the breathing tube in, I'm going to give them a heavy dose of a sedative hypnotic and a muscle relaxant, and I'm going to put the breathing tube in. There's a trauma to an airway, that's a whole different scenario. If I got a bloody, swollen airway, we're probably going to be thinking about going straight to a surgical airway.
So let's use that example of the pediatric patient with the traumatic brain injury, with just a very low GCS. We don't know whether or not the patient's going to be going to surgery, but we're throwing on the OR. We're in the back of the ambulance, the helicopter, or maybe in an ER room at best. What are your preferred sedatives? Are you typically going to be using propofol? Because that's the one thing that we don't carry. We have fentanyl and ketamine and Versed, but not propofol.
So I will add physiologic variables here that I know you guys are well aware of, is in the brain injury patient. Now they've got brain swelling. Now, physiologically, if they have brain swelling and they have airway obstruction, or they have a decreased level of mentation, they're going to be more likely to be hypercapnic. And hypercapnia further increases the brain blood flow and increases the ICP. I don't have a whole lot of time to play with that patient population. And that patient needs their airway secured so that they can get at least the transient benefit of hyperventilation and the protection of the airway. And you have to be aware that my inhalational agents wouldn't even be a good choice in that scenario, because they're also going to cause more respiratory depression and more brain swelling. My IV agent should be one that is likely to cause some vasoconstriction. So propofol would be a great choice if the patient is hemodynamically stable. So this is debatable. This is debatable. I think ketamine is not a great choice in that scenario, because I still believe ketamine does have increased cerebral blood flow associated with it, and so therefore might actually cause a increase in ICP. There is some literature suggesting that maybe that's overblown and ketamine might be reasonable. Ketamine itself is not going to cause enough transient increase in ICP to overcome the benefit of getting the breathing tube in as quickly as you can. So I'm not saying ketamine is contraindicated. I'm saying it's probably not my drug of choice.
And maybe don't use it for continuous sedation.
Absolutely. That's my opinion, based upon my knowledge of that literature. And then you have this question about succinylcholine, because succinylcholine certainly has been known to increase your ICP transiently. However, succinylcholine is going to give you the most rapid, optimal intubating conditions. And so the transient increase in ICP that might occur related to administration of succinylcholine is, in my opinion, definitely overcome by the fact that I'm going to have the best intubating conditions in the most rapid window of time. And I'm going to decrease the likelihood of the patient coughing and bucking while I'm getting the breathing tube in. And coughing and bucking while they're putting the breathing tube in substantially increases the ICP. So in my mind, succinylcholine is a drug of choice, and it doesn't matter what sedative hypnotic you give. Ketamine is probably not my drug of choice, but I would use it. If you handed that to me, I'd use the ketamine and succinylcholine, and I wouldn't hesitate. Fentanyl is a good choice because it's not a great vasoconstrictor, but it's not a vasodilator either.
For sure. Absolutely. So now let's talk about like TBI patient or a similar patient. Maybe it's not a TBI, but they're altered for pick any reason. Maybe a DKA, or something like that, where they are significantly altered, require airway protection, but they first require resuscitation because they have low blood pressure. And I know it's very scenario dependent because it's trauma, you give blood. If it's DKA, you give fluids, right? But how do you handle the resuscitation of a hypotensive patient pre-intubation? Do you have pressors that you prefer, like epi or levo, or more fluids than pressors? What are your preferences there?
Like you said, it's hard to know that based upon this. It would be scenario dependent.
Right.
But I would say this: it depends on the cause of their hypotension. What you think is the cause of their hypotension. Adequate volume resuscitation is absolutely important and indicated. Trauma guidelines or ATLS guidelines tell you they're hypotensive in a pediatric patient and you don't have obvious blood loss as the cause of their hypotension, then 20 cc per kilo volume and see if they don't get better.
Yeah.
Then if that doesn't work, you give them another 20 cc's per kilo of volume, and then you see if they don't get better. And if that doesn't work, you give them a third 20 cc's per kilo. So the ATLS guidelines are really specific. You need to give adequate volume resuscitation of crystal void solutions to those patients. You might be able to avoid intubating them if they're just super dehydrated. And it's only after that third round that the ATLS guidelines say, okay, now give them some blood. Unless you have an obvious blood loss.
Unless you have obvious hemorrhage. Right?
That's right. And then, of course, vasopressors to stabilize the hemodynamics while you're trying to volume resuscitate absolutely is indicated. In infants, you might not get as much bang for your buck with vasoconstrictor agents as you do in adult patients because they have incomplete sympathetic innervation, so they just don't have as substantial of a response. In those cases that I do choose to give a vasoconstrictor, I'm probably going to be giving volume, but then I'd probably choose to give nephrine more than I would phenylephrine and a little bit.
So in a little bit of babies where they have the incomplete sympathetic innervation, does that specifically affect alpha receptors only in the systemic arteries? Or does that mean that they also lack beta receptor response?
So for a different reason, their cardiovascular response might not be as vigorous as well. The younger they are, meaning infant or premature, the less contractile tissue they have as a part of their myocardial mass. And you and I, 6% of our myocardial mass is contractile tissue. The rest is conductive, connective, etc. In the newborn, it's about 30% of the myocardial mass that's contractile tissue. So when you give them an inotrope, they're less responsive to the inotrope because they don't have as much contractile tissue. In the preemie, it might be as low as 20-25% of the myocardial mass is contractile tissue. So they are less vigorous response to inotropic agents. They obviously do have response to inotropic agent, but less responsive. And then they're more prone to hypocalcemia. And calcium is a natural inotrope.
Right.
So in the really young kid that's hemodynamically unstable, you have to ask yourself, could it be hypocalcemic? Could calcium be a good agent to help with their hemodynamics?
How do you dose your calcium?
So we give calcium chloride, and the dose is usually 10 to 20 milligrams per kilogram per dose.
Okay.
Or if I'm giving blood products, for every 10 cc's per kilogram of blood products I give, I'm going to turn around and chase that in a separate line or in a cleared line with 10 milligrams per kilogram of calcium chloride.
Interesting. Okay. Would you say that calcium often is maybe sufficient to boost cardiac output or to augment cardiac output where maybe epinephrine or an inotrope is failing?
I would say that you might want to talk to a pediatric cardiac anesthesiologist or one of the pediatric cardiac ICU docs to see their response to this. But I would say this, typically in my patient population, before I'm even reaching for dobutamine or milrinone or epinephrine, I'm probably giving calcium first because calcium is a native, a natural inotrope. It's not a synthetic inotrope. It's a natural inotrope. Calcium often is sufficient to fix some hemodynamic instability, and then I don't have to give an inotrope. if calcium isn't working, then an inotrope is first it's probably going to be volume, then it's going to be calcium,
Yeah.
then an inotrope is going to be my next choice.
That's very fascinating. Yeah, that makes perfect sense. It's very fascinating. So last question about the pressors then. Let's just say this. Take the 4 big ones. I want you to rank them for me. Epinephrine, Levophed, neosynephrine, and vasopressin. And kids, especially the young kids, how would you rank them as far as effectiveness and preference of using them for hypotension?
Phenylephrine drops out of that list.
Uh-huh.
This is an opinion question.
Sure, of course.
But phenylephrine definitely drops.
Disclaimer at the bottom.
Yeah. Well, phenylephrine drops out of the list. It just completely drops out of that list. Vasopressin is the new kid on the block. It's only indicated, in my opinion, in some very specific scenarios or as a last-ditch effort.
Okay.
That then leaves me with Levophed and epinephrine. And again, it depends on your scenario. What I do know is that epinephrine tends to have more of a strong inotropic effect, whereas Levophed does have it has a more profound vasoconstrictive effect, but it certainly does have an inotropic effect. So I'm usually not going to Levophed for the inotropic effect, although I get the benefit of some inotropic effect. Epinephrine is probably the number one drug when it comes to looking for inotropic effect, but you also, at the higher doses, you're going to get a vasoconstrictive effect as well. At lower doses, you're going to get some peripheral vasodilatory effect.
A little bit of that beta too.
That's right.
Absolutely. That's everything else top of my head, Dr. Burt. What else? What did I forget to ask you? What did I forget to talk about? Because I don't know anything.
We've gone long enough, but we probably would be better talking to someone else, but we could talk comorbidities and things like that. Comorbidities are a big deal, asthma, sickle cell, cystic fibrosis, the package of the comorbidities that a patient brings makes a difference in their outcome. In the anesthesia world, you got the ASA physical status classification. You guys familiar with the ASA physical status classification? Okay. Forgive me if I insulted you guys.
No, it's okay. It's okay.
So when you look at morbidity and mortality literature, the ASA physical status classification impacts the likelihood of morbidity and mortality. You get to an ASA 3 patient, and they have like a 10-fold. I want to look at that. It may be as low as 10, but it may be as high as 30-fold increase from the ASA 3 to the ASA 1 patient. Wow. And then it goes up to 40% with the ASA 4 patient. So the ASA physical status really, really does matter with morbidity and mortality. The coexisting diseases and the physiological impact of the coexisting diseases changes the likelihood of a patient having a bad outcome. So when you guys go out there and that patient has other baggage, other morbidity, then they really need you to be aware of the physiologic implications and move with haste and urgency to address those factors to increase their likelihood of a good outcome.
Well, because you brought it up, very last one that I want to hit on quickly is the asthmatic then. How do you approach management of an asthmatic airway? Let's say in the acute phase.
I think there's 2 questions here. So there's the medical management of the asthmatic. You hope not to have to intubate the asthmatic.
Sure.
You hope that pharmacologic interventions, beta agonists, whatever, something to change the cyclic GMP balance and cause bronchodilation. You hope that those things work. Ketamine, you hope that those things work. Because when you do secure the airway, while it can be life-threatening, it can exacerbate the process at first, because the endotracheal tube is a noxious stimulus, and any noxious stimulus is going to potentially increase the likelihood of bronchoconstriction, which is what they're dealing with. Their whole life-threatening thing is they have bronchospasm. Then you go and put a breathing tube in there, and they're not deep enough. Then they may further bronchospasm. So you got the tube in, and you get no end-tidal CO2 because they slam down completely with bronchoconstriction. So, yeah, that's a big deal. So if my pharmacologic interventions aren't working and I do have to intubate them, what I want to do is make sure that that I minimize the likelihood of them being stimulated by the endotracheal tube.
Okay.
So an agent like ketamine is a great agent in that scenario, and a anticholinergic like Robenol or glycopyrrolate before you give the ketamine is also a big potential benefit because it increases the cyclic GMP levels, and so it may actually cause bronchodilation.
That's fascinating. Awesome. Well, that's all I have for you, Dr. Burt. That's all I got for you.
Appreciate you. Thank you so much for your